For today's procedure, first we'll use 6 or 7 French long sheaths for the vessel access and crossover. And we have a bunch of glide wires and wires for V18 command 14, glide wires for the passage. And the most important thing for today's case is IVUS, which is quite important for us to determine the character of the disease, right? And for the vessel preparation, it depends on the IVUS results. If it's mainly composed by thrombosis, we're using debulking methods, using rotor racks or strop. And if it's just mainly fibrinosis or soft plaque, we'll use just the PTA, progressive PTA. And for the final, we prepared a DCB, but just in case, we also have Vyban and the Illuvia, which is DES, just for different conditions. This is the first picture we've taken after we cross over. We can see the CFA, the SFA, and the DFA, which is fairly good, especially for the SFA in the proximal segment. But there's a severe stenosis at the distal SFA, which you can see there is almost occluded. Okay, this is a road map before we cross it, and it's quite clear. So this is a severe stenosis with a lot of collateral generated. So is it do you more inclined to the chronic disease like fibrinosis or soft plaque, or you think it's more like a thrombosis? It's hard to say, right? It's hard to say. That's why we're having IVUS here. So next one, please. 14, crossing the lesion, which is I would say quite easily just some angle and just cross it. Okay. And probably because just it's stenosis but not occluded, and I think we're good, right? So next, after we pass the lesion, we're using IVUS by the guidance of Dr. Dongyong Tai. Thanks you very much. And could you play the IVUS image?
After the Y cross the lesion, we perform the initial IVUS imaging. As we know, this is a very important intravascular image for guiding the precise procedure.
Exactly.
Okay, we can review the imaging.
So this is a lumen. Lumen is quite big.
Yes.
So I would say this gentleman's SF is quite big. Not like most of the Asian, more like a Caucasian, right?
Yeah.
7 millimeter around. And so are we? We're getting close to the lesion.
Yeah.
Going. Oh, there you go. There you go. So we can see that, and suddenly the lumen is coming back again.
Yeah.
And there's quite a lot of calcification, right, Dr. Gong?
Yes. The length of the lesion is about 14 millimeter.
14 millimeter.
Yeah.
So what do you think of the character of the lesion? Is it more like a fibrinosis or thrombosis? What do you think?
Fibrotic.
Okay.
Of course, in the severe stenosis lesion, they are lipid rich.
Okay. Some lipid plaque composed with fibrinosis. So are we good for the progressive PTA?
Yeah.
Dr. Song?
Yeah.
Okay. Okay.
After measurement, the distal segment of the landing zone, the lumen area is about 22, and the mean lumen diameter is about 4.5.
4.5. Oh,
yeah.
okay.
And in the most minimal lumen area is about only about 4.56 millimeter square.
So what about the proximal diameter for the landing zone?
For the proximal landing zone, the vessel is very big, and
of course, yeah.
in the plaque burden less than 14 persons, just need more than 14 length span.
40.
Yeah.
Okay. So the length is 40, the distal is 4.5, and the proximal is around like 7 millimeter, right?
Yeah.
Okay.
Okay, so it's quite differences, right?
Yeah.
All right, thank you very much, Dr. Gong. So shall we proceed?
Yes.
Okay.
From the under graph and the iris, we think this is a stenosis, and with the femoral fibrinosis.
Yes, yes.
So we use the gradual gluten PTA from the 3,
Okay.
3, 4, 5.
Okay.
Okay. So
Start from the 3. All right.
okay.
So there's okay. Can we get a 3? Through what?
Sterling.
Sterling. Can we have a sterling bloom for 3 or for how long?
100.
3,100.
3,100.
Okay. 3,100 sterling bloom, please. Anyone?
No 3. 4.
We have 4? Okay, no 3? So we have 4? 4 100? Uh-huh. 4 120. 4 120.
Okay.
All right, 4 120. Okay. Yeah. So 4 100. All right. That's what we want. All right, there we go. Okay, pump.
Roadmap. Yes.
All right. So we have 4 100.
Okay.
4 100. This is Saber.
Okay.
From Cardis.
Okay.
And
we use 2 guide wire.
2 guide wires. So, Dr. Sun, you are planning using 2 guide wires when you're doing PTA. So it's more like a cutting balloon stuff?
Yeah.
Okay.
It's also just like a scouting balloon.
Okay. All right. During this time, I actually want to bring some information about the why we doing this case and how we do it. So for our center, this kind of type task, I would say it's task A or B. Task A or B. Yeah. Task A lesion patients is quite rare. So most of the patients committed to our hospital and the center are mostly type C or D. So why are we taking this case to the live stream? That is because we can still learn a lot of stuff from this quite, I would say, fairly simple case. And so the strategy of deciding what's the character of the lesion, and the strategy of the vessel preparation, and the strategy of the final solution. So we can see the stenosis here by the blooming. It's quite significant, huh?
You can see.
Uh-huh.
Very okay.
Looks good, right?
Yeah.
Hopefully it's still good for the last one. Okay, so for the 6 mm balloon,
Uh,
it's going for both wire, right?
yeah,
Inside,
yeah.
both wire on track.
Because it's the 3-5 system,
Uh-huh.
the balloon,
Okay.
and
So you don't want the cutting effect for the
yeah,
6,
no.
because the 6 is quite large enough, right?
Yeah.
If you are still cutting, it's more like a generally dissection or perforation, hemorrhage, a lot of things we don't want to see.
Okay.
So people, you can see that. Let me emphasize again. This is a quite simple, quite easy case, but we can still now learn a lot of things from this simple case. So
Yes.
people, please notice that, and how we choose the different size of balloon, and how we adjust using different wires, and how we using wires
3 minutes.
to cross the lesion. So it's quite interesting. For 4 and 5 millimeter diameter, we're using cutting effect, and for 6, which is quite almost the same diameter as the vessel, we are losing it. We're just not quitting using the cutting effect. It's quite interesting. So thank you, Dr. Lin. This is pretty good. I learned a lot for myself. Definitely. So this one also go 2 minutes. 3 minutes.
3 minutes.
Okay, 3 minutes. After that, we're using IVS again, right?
For debugging, maybe like a duck or PMT.
Okay.
Oh, okay.
Mhm.
It's good for the vessel preparation,
Uh-huh.
but in China, it's maybe the
Mm.
expensive.
I know. Yeah,
in China.
I feel you.
Uh,
So yeah, definitely. People from the world, probably, this platform is broadcasting around the world. So, and people from different countries have different conditions for themselves. So we also see
Yeah.
some colleagues from U.S. Or some Western world using a lot of great instruments for treating patients. But to be honest, in China, we have to be accountant for the patients first, right? We have to calculating and for the expense for the patient. So if the patient's economic condition is acceptable, we probably will choose PMT or DART. But most of the people, we will choose a fairly cheap way
Yes.
to do the big thing, right?
So we use the two gear wire,
Mhm.
two gear wire for, and one is inside
Mhm.
and blue, and one is outside blue.
Mhm.
We use the cutting balloon or scalding balloon to expensive.
Yes.
Mm.
Cutting
Yes.
balloon. Yeah. Still, not every doctor has cutting balloon, right?
Yeah.
So we have to use some
That's
ways that we make by ourselves to make the effect, which is fairly good. Yeah, I like it.
okay. Yes. 3
There we
minutes
go.
is a minute. So we undergraph first and use the iris
To do it again.
Mm.
Okay, I was again.
Oh no.
Let's see if there's some restricted dissection. If not, we're going for using DCB for the good. So what if we have a restricted dissection for this lesion? Are we going for the standing?
Yeah, if we have the flow limited dissection, we use the jogging blue stand.
Hey, Dr. Sun, I'm
Yeah.
so sorry to interrupt you again. Even though you are not going to use IVL for this patient, but the audience is very interested in the use of peripheral IVL. They want to ask you if you have any experience about the use of peripheral IVL, like how many pulses a peripheral IVL may deploy.
Sorry, pardon me, please. So using IVL or something?
Yeah. If you use a peripheral IVL,
Uh-huh.
how many
Oh,
pulses a
Pulses.
peripheral IVL may deploy?
Well, how many pulses? Okay. So back on our old questions and old answers. Not every doctor has such advanced instrument. So I can be honest for the audience online. Um, for our center, we just using IVL just for once. So
Okay.
if you are asking, do we have a lot of experience for using that? I will honestly answer you that no.
Okay.
So we don't have such experience for using IVL, but we do have a lot of old school ways to dealing with such lesions, which is also good for our patients.
Mhm.
So they improve their quality of life. They are happy, and we don't expend that much money.
Mhm.
Yeah. So like I just said in the beginning, uh, uh, there's doctors broadcasting their treatments, their practice around the world on this platform, and different countries have different conditions. So you might want to know some advanced technology, but we also know the advanced technology, which is good for the patients, but for the actual condition, there's fairly we use it very less.
Okay, we got it. Maybe we have many approaches for the same case.
Mhm.
Here we got another question. Like they ask, what are the risks of recalcification and restenosis after this procedure?
After the procedure. Okay. So I think it depends on what we do next. If we will do if there's a no dissection, we're using DCB. There's a dissection, we're probably using a stenting. So I would say in old times we will implant a little bit longer
Okay,
stenting,
okay.
like
And the-
100
the-
millimeter.
okay.
But right now, I know in the Western company and
No,
some
no.
Chinese company also experiencing some
Well,
short segment of the
out.
stand, just
No,
for
no.
rescuing the
Which one is available?
dissection, which is pretty good. But we are still on the clinical trial.
Okay.
Our center is one of
Is
the
okay?
one of the centers for the clinical trial. So if it's shorter, standing definitely will be better than longer. They want to know the restenosis rate of DCB or standing for this segment.
30%.
Okay.
30%. Okay.
30%.
You can see the.
So this is the direct answer for that 30%. Yeah.
The plaque has been fully modified by the predilation, and we can in some segment there are dissection.
Oh, some dissection. Is
Yeah.
it? Okay. Which is not surprising, right? For some short segment of dissection and.
Okay. This is the proximal segment. It's very health segment, but in the middle segment, in the plaque and the severe stenosis, we can see the dissection. Dissection, as we know.
So can we using IVS to determine the types of the dissections, or we more depend on the angio?
Angio.
Okay. There you go. Angio. So is it because the most the current classification of dissection is based on the angio? Or you think angio is more like your way?
We'll go the model on
Okay.
angio.
Okay, so they're doing different angles,
Yeah,
and we can see the doing angio. We'll see if it's a restricted dissection, right? So now we are turning quite a bit angle, LAO, 35 degrees, and we're doing angio again to see if there's a restricted dissection. Is it good?
I think it's no.
I think it's good, right?
Yeah.
It's good for me. Some places more like the interference of the guide wire.
Okay, the dissection limited to the intimal.
Intimal, okay.
Yes, that means
Uh-huh.
it just plaque, crack,
Uh-huh.
not into the media. and we know if the dissection into the India, this into the media, which may
is bad for us.
have the risk of the extension to the distal segment.
There we go. Yeah.
Which one is the B?
Yeah.
Section?
Oh yeah, it's
Yeah.
more like a type B
Type
dissection.
B dissection.
So for the classification of dissections and
Which one?
is a type B dissection good for you, Dr. Sun?
Type B. Well, I think with type B dissection.
Yeah. So is it good for you? You think it's necessary for stenting?
I think maybe the balloon DCB is okay.
DCB is all right.
Yeah.
So for
we also can use the to test the blood, the blood pressure, the
distal and the proximal.
Yes.
So we can see the differences from the pressure, right?
Yeah.
To see if it's restricted.
So
what's the next? Do you think DCB is all right for this one? So we think type A and B is benign,
use
and
blood.
C2F is
blood for we use the NIC.
So in this case, we are going to use DCB, which is after special preparation, we can see a type B dissection. From literature, we think that type A and B is quite benign dissection, but if it's C to F, would be pretty bad. I think we definitely need some interventions for those dissections. But for now, we're good.